Hello, my name is Dr. Luciano Costa. I'm a multiple myeloma physician at the University of Alabama at Birmingham. And at the European Hematology Association meeting in 2023 in June, I had a chance to present on behalf of my colleagues from the COMMIT Consortium the final analysis of the master trial. So this trial was built on the combination of four very active myeloma drugs, dexamethasone, lenalidomide or Revlimid, carfilzomib or Kyprolis, and daratumumab or Darzalex. Those drugs were combined for 4 cycles and we'll call induction, and patients subsequently had autologous transplant. What was somewhat different about this trial is that instead of everybody getting the same therapy, what happened after transplant was very much influenced by the patients achieving a status that we call MRD negativity, which is less than 1 cancer cell per 100,000. And patients could receive up to 2 blocks of 4 cycles of this regimen with DARA-KRD. But if a patient had 2 consecutive MRD negative reads, for example, after induction and after transplant, or after transplant and one of those blocks, they went on to this phase where we did not do any further therapy. The patients stay off therapy, and they were monitored by routine blood work, but also by bone marrow-based MRD at some specific time points. The patients who did not have 2 negative MRDs to 1 in 100,000 went on to receive lenalidomide or Revlimid maintenance that is considered standard. So overall, most patients, 81% achieve some MRD negativity, and 71% of the patients achieve 2 consecutive MRD negative reads, and they transition to this observation phase that we call MRD-SURE. Now, we are analyzing the patients in terms of number of high-risk chromosome abnormalities, 0, 1, or 2 or more. And you see that the patients with 2 or more, they're less likely to achieve an even deeper level of MRD response, which is 1 cell in a million or 10 to minus 6. Now, when you look at how people did over time, the patients in general did quite well. Patients with 0 or 1 high-risk abnormality have an over 85% in aggregate progression-free survival at 3 years, which is very good, and over 92% overall survival. The patients with ultra-high-risk myeloma with 2 or more high-risk abnormalities had a 3-year progression-free survival of 50% and overall survival of 75% after a median follow-up of 42 months. When you look at patients, in terms of the MRD post-transplant, we know from the literature and several other data sets that patients treated the same way, the ones who achieve MRD negativity at some time point tend to do better than ones who do not. So here we see the opposite. They have a very similar prognosis, even though some patients are MRD positive and some are negative. And we believe that endorses the hypothesis that the further adaptation of therapy, in other words, treating for longer the patients who are MRD positive, account for the difference. In a way, can correct the negative prognostic impact of being MRD positive post-transplant. Now, when you look at the patients who specifically had 2 negative MRDs in a row and were able to stop therapy, 3 years later, progression-free survival is over 85%, except for the patients with ultra-high-risk disease. And overall survival is greater than 95% with no really difference between those 3 groups. Now, when you look at those patients who are being observed without any subsequent therapy, and here you have the MRD level over time, the majority of patients have this behavior here. They achieve MRD negativity, and despite no further therapy, they remain MRD negative. We had, however, 16 patients who had a progression of disease without any warning, so without any changes on MRD preceding that progression. And we had 7 patients who had what we call resurgence of MRD. So those patients don't have traditional progression. They don't have a reappearance of the M spike or symptoms of myeloma, but the MRD goes up. And in those patients, and the majority of those patients were able to resume some therapy and drive their disease to stability or back down to a MRD negative state. And a year and a half after the resurgence of MRD or progression, 100% of those patients are alive. So what we believe this data helps our future plans in myeloma is it further provides data that for the majority of the patients who have 0 or 1 high-risk abnormality, the outcomes with quadruple are excellent. The majority, over 80%, achieve MRD negativity. And with this approach where we cease therapy, the majority are doing well without resuming therapy and with a very low risk of progression. The patients with ultra-high-risk disease, they are a minority, about 10 to 15% of the patients in our practice, but they are a very challenging minority. And just continue to pursue MRD negativity with the current 4 main classes of therapy seems to improve their outcomes, but do not solve the problem. The outcomes remain inferior. So we believe future trials have to test drugs with new mechanism of actions. And we have a lot of hopes for the bispecific T-cell engagers or the CAR-Ts being introduced early in the myeloma therapy and hopefully improve further the outcome also for those patients.